Hello, good evening, good afternoon, and good morning. I'm Larry Cohn from Sydney, Australia. On behalf of the SOSORT Board, the SOSORT Education Committee, the SOSORT Communication Committee, it is my pleasure to welcome you and thank you for joining us for our third SOSORT educational webinar. The topic of our webinar today is scoliosis-specific exercises in adults with spine deformities. We have 5 amazing presenters. They are Eric Perrin from Canada, Fabio Zaina from Italy, Charles Crawford III from the United States, Sabrina Donzelli and Alessandro Negrini from Italy. While we are joined by almost 200 participants from around the world, and we look forward to the presentations of the speakers and the discussions that these presentations will generate. We will have 2 Q&A sessions, and we ask that any questions be posted in the Q&A section of the Zoom webinar platform and not in the chat, please. Please feel free to upvote any questions you wish to have answered live. However, we apologize in advance that we may not be able to answer all the questions during the webinar, but we'll try to do so offline if possible. A recording of the webinar will be available for all attendees and will be hosted on the SOSORT.org website. At the end of the webinar, we will send you a certificate of attendance as well as a short survey, and we request that you complete the survey so that we can continue to improve our webinars. The mission of SOSORT is to advance the most appropriate care for people with scoliosis and spine structural changes with an emphasis on non-operative management. Our vision is to foster a world where multidisciplinary collaboration among people with scoliosis and spine structural changes, their families, healthcare professionals, and scientists exists to ensure optimal outcomes. These webinars are one of the ways that we at SOSORT try and facilitate this collaboration. Other ways include annual meetings, and I would like to invite you to our next face-to-face and hybrid meeting in San Sebastian in the first week of May. So back to today's webinar. The format of the first component of the webinar will be Fabio and Eric presenting on evidence and management. And we will have a Q&A section, so please place your questions into the Q&A section. I would like to welcome Eric and Fabio to the podium.
Hello, it's a pleasure to discuss physiotherapeutic scoliosis-specific exercise for adults and whether they're supported by the evidence. Here are my disclosures. Before we dive in, we have to understand that adults with structural spine disorders are a mixed group. It includes 2 groups that were diagnosed as adolescents and still present with their structural spine deformity later on, and then 2 groups that have had the development of spinal issues in their adult years. It includes de novo scoliosis, which is typically associated with a lumbar curve pattern, with asceticism, rotation, back pain, and radicular pain and numbness, and age-associated kyphosis, which also involves some pain, stiffness, height loss, functional limitation, and an increased risk of falls and fractures. So they'll have different goals. Physiotherapeutic scoliosis-specific exercise are outpatient exercise therapies that are individualized for the curve type with published positive effect. There's a variety of approaches, but they share the common characteristics of teaching a patient an autocorrection in 3D, teaching them to stabilize this corrected posture, some education on how the structural changes affect their body, and training to maintain corrections in activities of daily living. These different approaches have been described by a paper from Berdzichevsky in 2016, and I refer you to that paper to learn more. Different goals can be pursued, and I look forward to our panel discussion to see what the relative importance of these goals is for adults with scoliosis. And with regards to guidelines and consensus to support the use of exercise, we have the 2016 SOSORT guidelines, which were mostly focused on growth, but now describe when exercise could be used for young adults, adults with no pain or pain later on in their mid-adult life, and in elderly patients with no pain, with pain, or with trunk decompensation. And what we find is that for low, moderate, and severe scoliosis, exercise is always part of the recommended intervention, either as the first line of care or as a moderate or more intense care level. So always recommend. The Scoliosis Research Society also recently presented a non-operative spine care manual for adults with structural spine changes because there's an important overall risk of complication from surgery, and they went on with reviewing the literature on this. So they found 26 papers comparing operative and non-operative care. But there was a problem with such studies because non-op care is mostly not defined in 84% of these papers. They don't name the treatment. There's 16% of these papers where they name the treatment, but they don't report percent of patients receiving each treatment, where when it is reported, it's typically less than 40% have received exercise. So that leads us to conclude that these papers document good results for surgery, so that's good, but they do not inform us about the effect of exercise. So with regards to physical therapy and conditioning, they argue that it's among the cornerstone of spine care, but that further research is needed to define the protocol and the long-term outcomes. With regards to the treatment for adults with symptoms due to spinal deformity, they say it should not be treated as non-specific low back pain, and it should be referred to physical therapists with adult structural spine disorder expertise. Specifically, it suggests to start with an examination to identify range of motion and strength limitations that are related to the movement dysfunction and the symptoms of the patient, and to build an intervention to address those things using either physiotherapeutic scoliosis-specific exercise, motor re-education, and cognitive rehabilitation. They also involve instructions on using ergonomics and activities of daily living in corrected positions. And they emphasize good communication with the spine team to outline clear goals such that it's clear when the exercise treatment has failed and it's time to move on to something more intense. Similar program has been recommended for hyperkyphosis, referred to physical therapy. If we look at the systematic review published on the effect of PSSE for adults, we find a review on shot exercise as a sub-analysis involving 3 cohorts of adults of small sample size, but finding some positive effect. And here it was an effect size that was combining all sorts of different outcomes, but it was positive. We had done a systematic review in 2018 and found 1 RCT, which I'll discuss. And there is a recent review that found a number of case studies, but 2 additional cohorts that I will discuss. And so the first cohort I'll discuss is on CS exercise, so scoliosis-specific approach. They offered CS twice a week for 45 minutes for at least 10 months per year to a group of adults with idiopathic scoliosis and moderate curves. And at the 2-year follow-up, they showed a modest improvement in the Cobb angle, but 68% of the patient had improved by more than 5 degrees with this program. There was a pilot study on the effect of shot therapy involving adults with AIS and de novo thoracolumbar curve with over 20 degrees. And they use shot best practice at least once a week, supervised for 4 weeks, and then a home program 3 times a week for 9 months. In the 12 of the 23 patients enrolled, they found some good results on radiographic parameters, small but good, and then on the SRS-22 changes as well, but not on all their outcomes. The most influential RCTs would be the RCT from Monticoni in 2016, where they randomized 130 adults with idiopathic scoliosis and curves less than 35 degrees to general physiotherapy or an experimental treatment. The experimental treatment offered CS or with CBT, where CBT focused on increasing the activity by reducing self-avoidance and teaching that scoliosis is a self-manageable disorder. The dose of CS was 60 minutes per week for 20 weeks, supervised in both, same in both groups, but there was 2 sessions per month of 60 minutes with the psychologist and the experimental group. The results were positive, little dropouts, and both at the end of the program and then at a 1-year follow-up later after stopping the program, they had good outcome on disability, pain or fear of movement. On the Cobb angle, it was modest at 4.3 degree difference between group, but it was significant. And then I would argue clinically important changes on the different SRS-22 domain, both after the program and later on. We have a systematic review on the effect for hyperkyphosis in adults as well. And so it included 7 RCTs. Of those, 3 were offering significant results. And when we try to analyze why, the ones that were significant had used extension strengthening, and the ones that were not had used either flexion strengthening or shorter programs. There was also cohort studies on that project. 4 of the 6 found positive results. When adherence was reported, it was generally good. And this program was typically offered for females in small to moderate sample size. Since then, there's been 3 studies published that have relevance to our RCTs comparing 2 active treatment, but finding that the more specific therapies are more effective. So a Sarman program and one involving chin tuck, spine straightening, and shoulder retraction was more effective. Katzman was reported in the previous review, but reported results at a 3-year follow-up, and some of the results were maintained even after patients had stopped exercising. We can stay tuned. There's a lot of registered trial with results upcoming, so that's promising. And in concluding, I would like to say, compared to adolescent, there is limited evidence on the effect of PSSE in adults with structural spine disorders, yet we still have our CT evidence of a combination between CS and CBT works for adults with idiopathic scoliosis. PSSE in general is recommended based on the consensus that's informed by the limited evidence on adults with scoliosis. And for hyperkyphosis, we have evidence suggesting it should be treated with extension strengthening and by avoiding flexion. And in future, exercise care should be explicitly defined and its dose quantified for future studies such that we have better evidence. Thank you for your attention.
Ladies and gentlemen, welcome to this lecture about the role of exercises for adult scoliosis. This speech will be related to the indication of exercises compared with other treatment options for adults suffering with scoliosis. I have nothing to disclose with respect to the topics of this presentation. The indications that we can apply in adults with spinal deformities, namely with scoliosis, are coming from the SOSOR guidelines, and they were a synthesis of the best available evidence dating back to 2016. So it's not really fully up to date because some new papers went out later on. In this paper, there are indications for the application of exercises for adults with scoliosis, and there are indications also for other treatments like bracing and surgery, because it's clear that there are different options for these patients and that the choice must be really based on a discussion on the pros and cons of each option. The final synthesis of the literature evidence is presented here in this table, which lists different ages and different size of curves, and for each of them suggests possible solutions in terms of exercises, bracing, surgery, and all the approaches that have a scientific base. Of course, the final decision on each single case comes from a discussion between the physician and the patients, because there is no need to choose a specific treatment, but it's always an option given to the patient. We are used to speak about adults with scoliosis, including really different ages and including also different kinds of scoliosis, because we know that there are idiopathic scoliosis that are progressing or not, but they are present even during adulthood. And then we have de novo scoliosis, which appear during adulthood in previously straight spines. So the approach, of course, should be personalized on a single base and should be discussed with the patient. And also an indication coming from experts should be customized. So we can group roughly patients in young adults adults and elderly based on the age in which they come to our facility for managing their problem. Usually for young adults, the main issue is prevention. They can come with large or medium curves, usually untreated. Sometimes we can have to face previously treated curves. Basically, at least in our experience, they have been treated only with bracing and not with exercises. And in these cases, it's useful to teach some specific exercises, and namely the active cell correction to patients in order to prevent possible progression or to face it and to give some active tools to patients to manage themselves. Only in a small number of cases, we can apply what we can call a real treatment focused on pain and disability, because usually in these younger ages, patients are totally asymptomatic. During adulthood, it could be a problem both of prevention and treatment. Preventions apply to asymptomatic large curves or patients with some degree of sagittal imbalance, even if we must say that usually the sagittal imbalance occurs later on during the life. For the treatment, the focus is mainly about pain and disability, or in case there is a progression already documented and cases where we need really to stop what's going on and stabilize what we have. Later on in elderly people, the problem is usually more related to the sagittal imbalance more than the curve itself on the coronal plane, even if there can be some degree of lateral decompensation. And again, this is a problem mainly of prevention of a further progression, but can be also a problem of treatment, because there can be some degree of pain and disability and an already documented progression. So in these cases, the exercises are focused on these. Some papers have already documented the possibility to slow down the rate of progression of the scoliosis during adulthood, and it's important to apply the exercises, the specific exercises based on active cell correction in these patients. There are also, or there can be also, problems of pain and disability, and exercises have documented also some benefits on this side. Another possible option is bracing. Bracing can be during the night or during the day, according to the patient's desires and expectations. While nighttime bracing has almost no side effects, there can be some side effects when we brace during the day, and namely because of the potential loss of muscles and strength. But the suggestion is usually to perform together exercises and to apply the brace. So it's always a combined approach. We must say that some patients are really not willing to do exercises. So in these cases, applying a brace could be an option and must be considered, because in evidence-based clinical practice, we have to focus on the patient's desire also. Last but not least, there is a role also for surgery. We are in a conservative treatment setting, but we have to discuss with our patients also the option of surgery, because some can be more prone to this with respect to a more different and difficult also treatment, like the conservative one, which needs to be constant, to be committed and regular in doing the exercises or in the brace. So discussing the option of surgery is always important for our patients. So that's all for this presentation. I hope you enjoyed the speech, and I'm here for further questions and a discussion with the panel of experts. Thank you very much.
Thank you, Fabio and Eric. Fabio, it's good to see you out in the sunshine. Eric, if I may begin with the first question. Your presentation suggests that there is less evidence for PSSE in adult scoliosis than there is in adolescents. Do you have any thoughts on why it is so difficult to conduct robust RCTs in adults? Is it a trial issue? Is it an efficacy issue? Can you expand on that?
An interesting question. I'd say we recently started a couple trials with adults, one for the adults with idiopathic, one with the adults with degenerative. I don't know if it's the pandemic, but our recruitment has been very difficult. I suppose once you start considering exercise in the older adults, then there's maybe less of a tendency to pursue this form of treatment in this population. There's some that embrace it and that are very happy to try it, but I would say it may be less of a first line. And because there's maybe less evidence to start with, I think it's harder to convince referral sources to encourage people to seek participation in our trial. So that's one option. And the other option, we've experienced that with adolescents as well, but to conduct a randomized study, you need people willing to agree to delay their access to the what they perceive the effective treatment or not receive it at all. And so I think with adults who have the capacity to pay and seek the care in the community, they might be less willing to do randomization. We haven't tested that just yet, but there's maybe an obstacle there.
Thank you very much, Eric. Fabio, we had a question on bracing, which you touched on. Can you give us some brief kind of insight in your experience with bracing? Do your patients prefer nighttime or daytime bracing? Have you seen any efficacy changes with the bracing that you apply?
Thank you for the question. Yeah, actually, I must say that personally, I prefer, even if this was not a question, I prefer to brace during the night because I think it's better because it has less side effects and it's good for patients to get used to the brace. Then I allow wearing the brace for some hours during the day. That's good. Maybe when they have to do cooking or ironing or spend many hours standing, that would help a lot. Then I must say that patients sometimes are a bit skeptical about using the brace during the night because they feel good at night and they refer problems during the day. So they say, why should I do that? It's better if I wear it during the day. So sometimes there is this negative attitude, and then I follow what the patient prefer, even if I try to push a little bit them in the direction I think it's the best one. But we are really at the beginning of this path about really starting collecting evidence about bracing for adults. So this is just really the starting point. It's not the end.
Thank you, Fabio. For those of the, we've had a number of questions on bracing, which we're very excited about. Just to let everybody know that the next sort of educational webinar will be on adult bracing. So we haven't set a date yet, but stay tuned. It will come sometime after our annual meeting, but we are working on a dedicated webinar for adult scoliosis bracing. Fabio, we had a question on scoliosis-specific exercises after surgery. So, Eric, if I can ask you first, have you seen any research on anything on literature on PSSE for post-surgical? And then, Fabio, do you have any experience?
As far as I know, there's very limited evidence for programs either to prepare a patient for surgery or immediately after. I think it's now part of discussions and consensus and as considerations, but in terms of finding evidence to document how well that has worked, I think we're really early in that process.
Thank you. And Fabio, your experience, have you done anything post-operative with your patients?
Well, in terms of research, no. In terms of real rehab for some patients, yes, we did, but very, very few. It rarely happens that patients after fusion come to us, and usually are those patients with some problems, then we try to do some exercises and we can get some degree of improvement. But it's really a small population. We don't have strong data in EasyCo, strong numbers about this kind of population.
And Larry, if I may follow on that, the little bit of around the consensus for the use of the exercise, it would be indicated to maybe prevent adding on or complications beyond the surgeries, and possibly address some residual posture changes or pain issues related to that remain after the surgery. So those would be the indications, but there's not a lot of evidence on how well it has worked.
Okay. Well, we will soon hear from surgeons and physiotherapists and physiatrists in that kind of field, and I look forward to those discussions. Eric, what do you see as the future for adult scoliosis? It's taken many years for us to get some form of, I guess, robust efficacy or agreement that there may be a role. Do you think this role will continue for adults?
I think there's a growing interest in studying it, partially possibly because we've now documented that the sagittal imbalances are related to quality of life issues. There's more documentation about how much pain and how much disability there is related to the condition. And so there's intentions to study it with different exercise programs, as we saw with the registered clinical trials. So there's definitely a number of those. And there's a spectrum. So if we tackle these populations early, then we may have a chance to maintain good function, maintain better health. I'd say historically, we may have left them alone because we trusted that once the skeletal maturity was achieved, that the idiopathic scoliosis was not necessarily causing severe problems in adults. And for the idiopathic group, I would say it's generally true, but there is a portion of that population that will seek treatment for pain, and I think there's potential for us to do something about that. And some of them are still wanting to address their posture or maintain their fitness in the best way possible for their curve, and our scoliosis specialists can contribute to that.
Thank you. Eric, we've had a question on camptocormia. Do you have any kind of advice for those kind of camptocormia post-Parkinson's severe kyphosis patients?
Yeah, there's again some evidence on that. I did part of a sabbatical visiting Bordeaux, where that was a topic of interest of the team I was visiting there. And so some of the documentation I presented on hyperextension exercise strengthening appears to show some benefits there, but again, it's some population that needs better evidence. But it appears that we do have a potential to train this hyperkyphosis there, and supporting it with bracing in anecdotal clinical practice. It was used there, but again, we need more evidence of that.
So in your mind, do you feel that camptocormia is a more structural change? Because we've seen some data when you lie these patients supine, they do tend to straighten out. So is this
Correct.
more of a motor control muscular issue, or is it more structural?
There's definitely a muscle dysfunction associated with the hyperkyphosis in this group. So some people have argued that there might be muscle atrophy, maybe motor control issues with regards to upright posture. I think we need more research to really dig down to how it should be treated.
Okay. And Fabio, what's your findings with camptocormia and some of the neurological progressive diseases?
Yeah, actually, it's not really another population that we see so frequently in EasyCo, but I agree with what Eric was saying. And theoretically, one of the differences should be really the possibility to strengthen the spine when they lie down. So showing that it's more a postural, connected to the neuromuscular and so on issue than on a structural issue. So this makes the difference. But also in Italy, there are some experts in the field, and we are looking for them together with the Center from Bordeaux and other people around the world to publish soon some data and see what happens.
Okay, and just one last question on the follow-up for the older patients. So those patients who are not braced or those patients who are braced, what is your current follow-up procedure for these patients?
Well, usually I have a first follow-up at 6 months, then I move it to once per year to check that everything is good, and then they have more frequently meetings with our physios to change their exercises, to update the exercises. So there is also a control somehow of how the brace is doing in that age. So this is more or less what we are doing now.
Thank you very much. Eric, Fabio, thank you very much. Thank you very much for giving up your time to teach us.
Pleasure to be here.
I'd like to call up
you.
now the next 3 presenters. We have spinal surgeon Charles Crawford III from the United States, physiatrist Sabrina Donzelli, and physiotherapist Alessandra Negrini. We look forward to your presentations.
My perspective as a spine surgeon. Just a brief little introduction. I am an orthopedic spine surgeon. I did a fellowship in adult and pediatric spine. I work at a large tertiary spine center, professor in the Department of Orthopedic Surgery at the University of Louisville. I've been a Scoliosis Research Society member since 2008. And I've done a lot of work with the Evidence-Based Medicine Committee for the SRS as well as NASS. Also a co-investigator for the NIH-funded adult symptomatic lumbar scoliosis trial. So when we teach the medical students and residents and fellows about adult spinal deformity treatment and evaluation, we like to draw the distinction between pediatric or adolescent spinal deformities, where most of our treatment recommendations are based on radiographic characteristics, and really patient-reported outcomes are considered secondarily, as opposed to adult scoliosis, where most of our current treatment recommendations are based on pain and disability, with the radiographic characteristics considered secondarily. And it's frequently more of a lumbar issue than a thoracic issue driving the patient's symptoms. And so when we think about adult spinal deformity, we can think of de novo lumbar scoliosis, which is also termed degenerative lumbar scoliosis. We can think about idiopathic patients who had a juvenile or adolescent spinal deformity that progressed in adulthood. Sometimes you might consider it a delayed adolescent idiopathic scoliosis surgery, where some of these patients have actually had prior surgical treatment as an adolescent, and then they developed adjacent segment or adding on phenomenon that needed treatment as an adult. There's post-traumatic deformities, including some patients that have osteoporotic fractures. There are neuromuscular conditions that lead to adult spinal deformities. And then there's iatrogenic patients who have had surgeries and have developed deformities within those surgical regions treated previously. And so really it's a heterogeneous patient population. And these are all adult spinal deformity patients from my practice. And of course, I'm showing all these coronal images because we're a little bit focused on scoliosis a lot of the time, but these patients also have sagittal plane deformities that are equally, if not more important for driving their symptoms. I'd be happy to talk more about that in the discussion. But really what drives a lot of the patient's symptoms is their spinal stenosis related leg pain. So they get lumbar radiculopathy, they get neurogenic claudication, and then they can have deformity related spine pain as well. Facet arthrosis, disc space collapse, muscle fatigue and strain related to regional and global imbalance. And then with really, really severe deformities, we'll see the rib cage resting on the iliac crest, which can be painful as well. So there's a patient with lateral recess and foraminal compression in her scoliosis, had a very severe L5 radiculopathy symptoms, and we eventually treated her surgically, but we evaluate this with the CT myelogram or an MRI. And so how do we get here, right? What's the literature kind of history that guides our current treatment recommendations? And so if you go back around 2007 or so, we started seeing these series of really high quality studies from a large database, multi-center studies, driven a lot by the Spinal Deformity Study Group, showing that patient-reported outcome measures can measure the health-related quality of life in these patients, and that surgical treatment really does improve these patient-reported health-related quality of life measures. While the non-surgical treatment that was done in these database patients really showed no significant changes in these groups of patients and their patient-reported outcomes. And that was true in the Spinal Deformity Study Group, as well as that previous article from the Harvard group. And if we divide these down into more specific types of symptoms like leg pain or back pain, we see the same results where surgery significantly improves the symptoms and the non-surgical treatment really does not. Those patients stay about the same. But we know that surgery has complications, especially in older patients. And so we've really looked at this quite extensively. And we've written review articles looking at the health impact, how you evaluate and manage these patients. The SRS has worked with the UCLA RAND group, developing appropriate use criteria for surgery in these adult spinal deformity patients. And we participated in this NIH-funded adult symptomatic lumbar scoliosis study comparing operative to non-operative treatment. And the 2-year results were published in 2019 by Mike Kelly. And really, this study showed what a lot of those older studies from the previous decade had shown, that patients treated with surgery have improvement in their patient-reported outcome measures, but that non-surgical treatment more or less maintains or keeps patients the same. So really, we use this a lot in our decision-making, our counseling of patients. If they have a set of symptoms that they feel like they can live with and they don't expect much improvement, they can continue with non-surgical treatment. If the symptoms are so severe that they would consider having a very invasive surgery with some significant risk involved, then operative treatment can offer a benefit. And we pay a lot of attention to the risk and the complications, the unplanned reoperations. This is one of the studies that I first authored, looking at the reoperation rate and the reasons we reoperate on some of these patients with complications. And certainly we've done a lot of work to try to minimize this. When you look at the literature recently, this is a 2019, 2021 articles looking at surgeon and patient attitudes about scoliosis specific exercises. You can see there's a lot of variety of opinions about the effectiveness, and I'll be happy to talk more about that in the discussion. I think from my perspective, SOSORT is a fantastic organization that can really help us understand what type of patients, what type of symptoms really truly benefit from scoliosis specific exercises. Is it non-operative patients? Is it pre-surgical patients? Is it post-operative patients? And with better data and peer-reviewed literature, SOSORT can help convince patients, payers, and surgeons that scoliosis-specific exercises are worth the time, money, and effort. And I thank you again for the opportunity to be here today, and I look forward to the discussion.
Hi everyone, it's a great pleasure to be here with you today discussing about scoliosis specific exercises in adult deformities. Here's my disclosures. So I would start with by talking about patient values and expectation. They come for a visit because they want aesthetic improvement, reducing their pain, but also they're worried about the Cobainum and the progression of their curves. And they are complaining about issues related to function and quality of life. Most of the patients we see in our facilities are refusing surgery. How can we help them? I have two questions. Is it possible to improve the aesthetics with conservative treatment in adults? But what is the role of surgery in improving aesthetics in adults and elderly? I think there are limitations, probably bigger for conservative treatment, but still limitation even with surgery. Then pain is one of the reasons for seeking surgery for most of the patients. But then we know that sagittal balance is important in adult life to prevent pain. We know that sagittal profile is often compromised in adult idiopathic scoliosis. And we see that pain is not strongly correlated to Cobainum, and the prevalence of low back pain is very similar to the general population. Rather than pain, most of the patients I see in everyday practice are asking for help to improve their function, quality of life, and disability. Generally, they complain about difficulties in standing or walking for longer period, or keeping a fixed position like traveling for hours can be a challenge for them. So they are asking for an improvement in their function rather than pain. What we have seen, thanks to Schwab studies, is that coronal angle, sagittal spine and pelvis correlate to disability, and surgery can really change those parameters while stopping the progression. From observation of adults with idiopathic scoliosis for the entire life, we know that those with most severe curve exceeding 50 cup degrees, there will be a progression, which was on average 1 cup degree per year. But then in reality, we don't know when this progression will start and what can happen to those with milder curves. We see many subjects with stable curves, even more severe than 50 cup degrees, no symptoms, refuses surgery, and for asking for conservative treatment here. Observation in those patients can be very useful in order to detect potential factors involved in the progression. But here, what we know is very little. We know that there are different forms of scoliosis and their behavior is different. So degenerative scoliosis have a different behavior than idiopathic scoliosis in adulthood. Curve localization, event like menopause can affect and enhance the progression. And also some radiographical characteristics can be important to be detected in order to predict the potential risk for progression. And observation is very important for a patient refusing surgery and seeking for conservative treatment. And prognostic factors can be different from idiopathic forms compared to the neurodegenerative forms, which are also localized in lumbar part of the spine. In a recent study, which is not published yet, we found that after age 50, the progression of scoliosis is faster than previously, and therefore we should recommend shorter period between follow-up. You can see here the description of the selected sample of adult subjects. Another study found that hyperkyphosis is related to age, and its increase starts around 40 years of age. So coronal progression is associated to sagittal imbalance, and some compensatory mechanisms start acting to keep the gaze horizontal. One pivotal role of scoliosis-specific exercises is to maintain compensatory mechanism together with stop progression or slow down the progression of the pain. So in summary, the components of clinical decision-making include the history of the patient, the clinical evaluation, but most importantly, patient values and needs, and should also take into account radiographic assessment and risk estimations. So scoliosis-specific exercises in adults with spinal deformity include preventing progression, preventing sagittal imbalance by improving compensatory mechanism, and reducing pain and function. We need to know that probably scoliosis-specific exercises have a limited role in improving aesthetics. Improvement in pain and function is possible, but at long term, and PSSE requires an active engagement because passive treatment have not demonstrated any effectiveness. And finally, with conservative treatment, we work as a preventative treatment, and therefore time and age are of paramount importance. And thank you for your kind attention. Thank you very much.
Good morning, good afternoon, good evening, wherever you are in the world. I am a physiotherapist, and my aim is to present what drives the decision-making process in the choice of specific exercises for adult scoliosis patients. This is my disclosure. Other patients with scoliosis look for help because of back pain, reduction of function, aesthetics and quality of life compromised. They feel they are worsening. They are worried because they expect to go on worsening also in the future. What improvement can our patients expect from a non-surgical therapy with specific exercises? In the randomized controlled trial by Monticone, adults with scoliosis performing exercises improved disability, pain, kinesiophobia, catastrophizing, and quality of life, and the effects lasted until the follow-up 1 year after the intervention. The experimental group performed active self-correction, task-oriented exercises according to SALES approach principles, and a cognitive behavioral treatment. The first step is a complete evaluation. The gold standard of scoliosis clinical evaluation is Adams test. However, from the literature, we do not know if this test is valid in adults and if there is any correlation between Adams test and COP degrees in this population. Coronal and horizontal plane deformities are less related to pain, disability, and quality of life than sagittal plane imbalance. The physiotherapist needs to evaluate clinically the sagittal plane at start of treatment and then every 3 to 6 months. Check the effects of the therapy and choose exercises tailored on the patient. Plumb line is a cheap and easy to use device. Plumb line distances have a good intra-rater reliability. To evaluate if lordosis is reduced, with the plumb line tangent to the apex of the kyphosis, we know that L3 plumb line correlates with lumbar lordosis COP degrees. In a healthy population, 6 to 18 years, the normal distance in L3 is 40 plus minus 15 millimeters. In this patient, the distance is reduced to 5 millimeters. One of the most important measures is the amount of anterior imbalance. With plumb line, we need to measure where C7 is in respect to S2. This is called clinical sagittal balance. It is a parameter evaluating the global balance of the trunk. It is calculated by subtracting the S2 distance from the C7 distance. It is a clinical measure similar to radiographic sagittal vertical axis. Normality in a growing population is 20 plus minus 15 millimeters. In our patient, Sagittal balance is 60 minus 0 millimeters, that is 60 millimeters, is higher than normal, showing an anterior imbalance of the trunk. Another clinical measure easy to use is the occiput wall distance. The patient stands with both heels and the sacrum against the wall, and with the head positioned in the Frankfurt horizontal plane. And then the distance of the occiput to the wall is measured with a ruler. What drives our decision-making in the choice of the active self-correction? The decision-making with adults is different from adolescents. An adolescent is more elastic, can reach a good correction without an effort, and use it in the everyday life. In older adults, the main direction of the correction is the elongation, to contrast postural collapse. While elongating, patients obtain most of the correction also in the other planes, together with lumbar or thoracolumbar extension, and often also pain reduction. What we ask them is not to push the spine towards the shift and the rotation, simply to elongate. In time, we can add more specific movements, while elongation remains the basic movement. They need to improve the capability to maintain the elongation of the spine. Sometimes it is necessary to increase the mobility of the spine towards extension, to prepare the structure to perform a better correction. These exercises can have an antalgic effect. Since the very first sessions of exercises, the patient must start exercises in sitting and in standing, not only lying down, since he should improve the ability to reduce the postural collapse. At the beginning, the patient can use some tools to help the correction. As soon as possible, we will remove these helps, since he must be able to reach an active self-correction also during daily activities. Another example of exercise. This is a teacher in high school. She performs the self-correction, then she pulls up the therband to increase the strength and resistance of the anti-gravity muscles of the trunk in a working posture, this sitting. To stabilize the correction, this patient pushes on the wall on the side. Exercise is repeated in active self-correction in both directions, to the right and to the left, to improve the stability of the trunk in correction. The best task-oriented exercises are the request of doing something in everyday life, maintaining self-correction, setting the table, riding in the lift, driving to work. Speaking to our patients, we can find the best option. For example, we can ask our patient to always walk to work in self-correction for the next month. Then we change the task. The presence of psychological factors, such as catastrophizing, kinesiophobia, maladaptive coping strategies, mood disorders, contribute to chronic symptoms, and treatment includes cognitive behavioral therapy. Patients should be educated to view scoliosis as something that can be self-managed. Patients can fill some questionnaire, also the Disability Index, Roland Morris, a scale of kinesiophobia, EasyCall, SRS 22. From this questionnaire, the physiotherapist can identify the back-stressing activities for each patient and discuss with them to find solutions. For instance, if the OD questionnaire shows that because of pain, the patient can walk for less than 1 mile, we will try to improve the resistance in walking through exercises, and we will propose to the patient some tips to increase the distances he can walk without pain. Rackets, backpacks to reduce the anterior imbalance. Thank you for your attention.
Thank you very much, Charles and Alessandra and Sabrina. We appreciate your message. We'd like to welcome all the presenters back onto the podium to have some discussion. So I'd like to start off with a short comment that was tabled by Sanya, the chair of the Education Committee. She writes that as clinicians, we must remind ourselves that we do not need to be alone in the clinical decision-making. And there's a clear place for a physiatrist, a PSSE therapist, a surgeon, a psychologist, and all other clinicians. So in the perfect world where there are no limitations, what would be the most effective, well-coordinated, multidisciplinary team approach to improve the quality and care of these patients? So in your perfect world, so Dr. Crawford, it's lovely to have a surgeon available to us. How would you envisage our helping our patients in these kind of situations? What would you propose?
Yes, absolutely. I think multidisciplinary approach, to these, especially the severely affected patients, is really, really valuable. Taking care of adult spinal deformity from a surgery perspective is not an easy task. It can be very daunting, for the surgeon and the patients. Occasionally we can do small surgeries that help people, right? There are patients with scoliosis that sometimes need a simple microdiscectomy surgery, right? So I think in some ways we have to differentiate, surgery from surgery, right? There's lots of different types of surgery, just like there's lots of different types of physical therapy. There's some different types of bracing, et cetera. And so I think that using, really specific language helps. But I think we have to work together, both from a research perspective, but also from a clinical taking care of patients perspective. We have to communicate well. It helps if we use the same language, to describe the problems. And really understand, things like camptocormia. Somebody talked about camptocormia earlier. That's very, very different than a 40 or 50-year-old with idiopathic scoliosis, right? That it's a totally different patient. So I think using specific terms and using those terms accurately helps us all. But yeah, absolutely. I could talk for a long time about this, so I'll stop.
Okay, Sabrina, as a physiatrist, would you contribute?
Yes, I agree that medical doctors should use the history and evaluation to guide the decision. Then we need to listen to the patient, but of course, we need also to guide them through the best choice for them. I like to see the treatment for adults like we see the treatments for growing subjects, like different steps. So generally conservative treatment should come earlier than surgery and not reversal, because sometimes we see surgery treated patient going back for conservative because they still have pain or things like that. So my suggestion is that in conservative treatment, we should avoid to arrive too late in some cases, because in some cases, patient could have significant advantages from surgery. And it would be interesting to know the timeline. And I know that this is a big challenge also for a surgeon to understand the best window to perform surgery. But I used to explain this to the patient, and if they are starting thinking about surgical treatment, my suggestion is to ask for a consultation in order to understand which could be the best window. For those refusing surgery, we need to explain that probably they will lose that train, and so at a certain point, surgery will not be available anymore, but it's their choice. And we conservative, we can still do something, helping them, improving or compensating, sometimes just a little, the issues they have, but then it's their personal choice. And it's not a threatening life condition. So we need to listen also to them, advising in the right way, but also listen to them.
Thank you, Sabrina. So let's go to the other side of the world. Eric, do you have anything? Can you contribute?
Well, you were talking in the question in terms of coordination. I'd say we do a much better job at coordinating our activities in the adolescents than we do with the adults. At least in our setting here, we have a very core team-based care for the adolescent in the children's hospital. And then there's a transition that's forced just because of how our health system works. And then it's mostly private offices, private surgeon office, private physiotherapy office afterwards. So I think there would be value, if not to have a team center, to have a network coordination with maybe better communication between the different players involved. So I think there would be value in that. If I refer to the document recently published by the SRS on how to coordinate the non-operative care of the adults, one of the key points is to have clear communications for setting goals at the different stages of the treatment, so that it's clear how long you beat a certain treatment before you move on to the next step. So that would be something I would encourage you to communicate with letters with the different practitioners involved with the care, and update on the progress and outline where we're at with the care of a patient.
Thank you very much, Eric. Fabio, what is your perspective in the perfect world? How would you envisage working in the multidisciplinary team?
Yes, sorry, I have problems in hearing you. Can you hear me? Because I moved to the station, I'm sorry.
Yes, we can hear you.
Okay, so the question was basically about the team and about when to act, correct? Yeah,
Yes.
The team is fundamental, and I think that the shared decision making is fundamental. So it's really to put the patient in the position to take their own decisions based on correct information, on fair information. So every member of the team should give this information in the best possible way, in the most neutral way, and allow the patient to take the right decision, which is really personalized and not the same for everybody. Then, especially with the conservative, if we can act earlier, it's of course better than if we wait too much. And this is part of the path, I think.
Thank you very much. Alessandra, we'd love
Yes.
the best for last. Let us hear your thoughts.
Since I am the last, since I am the last, I would like to start from the opposite side and not speaking about what we should do to have a good team, but which are the problems since we are not able to get a good team. And I see mostly two problems. One problem is time, because when I call you, when I write an email to you about this patient, maybe you have not the time to answer to me because you are busy, because you are with another patient, and we lose this specific moment where we can discuss about the patient, and time goes by. And the other problem is, I guess, humility, because who are you, physiotherapists, who are coming to me, orthotists, and tell me that you don't agree about this brace? Who are you, physician, who tell me, physiotherapist, which exercises my patient should do? And so in the team, we need time, find the time to speak, to discuss about the patients, about the difficult cases, and find the humility to listen to the other professionals, to get something useful for us, and maybe discuss it. Maybe they're wrong, maybe they're right, but this is the only way to get the team.
Sandra, thank you. I love your comment because it precedes what I'm about to say. I think we would all love to live in a perfect world, but unfortunately, we all learn from our mistakes. So if I can turn the question around, and so back to each individual. So Dr. Crawford, what has been the most frustrating experience you've had in working with non-operative management that you could teach us in order to help us kind of become aware of these situations so that we kind of learn from these mistakes that others have made? So what frustrates you?
I think the most difficult thing for our patients is time and travel, and the heterogeneity of physical therapy that they receive. Not everybody is trained in scoliosis specific exercises. And so if it really is better, how do we get it, more disseminated to the physical therapist around the country, so the patients don't have to travel several hours to receive treatment.
Okay, Eric?
For me, it's access, and I'm speaking from the research point of view, where when I do want to enroll these adult participants in trials, they're hard to get. It could be a pandemic kind of thing, but they're not necessarily all concentrated. They go to different places. So they visit physiotherapists, they visit primary doctors, they visit physiatrists, they visit surgeons, and it's widely spread. So I think the other aspect that's also frustrating is a lot of the evidence we have is on a mixed bag of this population. And when I try to draw a conclusion in terms of what should I offer, it's hard to come up with a specific protocol when the impairments and the issues that the different patients that are lumped under adult spinal deformity, they're very different from amongst them. So I think we will help ourselves once we start maybe looking into this heterogeneity and trying to find some better protocol for different subgroups of that group.
Thank you, Eric. Fabio, can you kind of expand on what you think the most frustrating thing is working in this environment within the team, or working with problems with the team?
Yeah, mainly it's when we have failures, patients who are trying to do their best, who fail due to the pathology, which is too aggressive for them, and to the lack of knowledge we have, because we have a very superficial knowledge today. And so that's why we need to do more research, to have more data, and to be able to help the patients also to figure out what the prognosis can be much more in advance. So to go to the best option for them as soon as possible. This is more or less what frustrates me today.
Thank you. Sabrina, would you like to expand?
Yes. We have frustration during clinical activity, but I think that the main one is related to research, because with adults with spine deformities, we are still facing a lot of challenges. One of the most important challenges is the time, and we need longer follow-up. Otherwise, we risk that we will never detect anything, because the progression is very slow and prolonged during time. So this can be frustrating, because we need evidence in order to advise in the best possible way our patient, and we still have some weak information from that. I think that nowadays, and I understand the effort from Eric related to trials, but I think that we have some great opportunities coming from real world data, and we should go more further with database or registry collection of data, because this will provide longer period observation of different patients, allowing different classification, because we have a large heterogeneity in adults. And so differentiating treatment will be possible when we will be able to classify patients. So probably real world data, databases, registry can be a big opportunity to study in the best possible way adults with spine deformity, and then reduce the frustration in everyday clinical practice.
Thank you. Alessandra, do you think that will be sufficient to reduce your frustrations?
I don't think so. I we pointed out very different frustrations, and mine is my biggest frustration is the one I share with the patients. It's frustrating for both of us. That's when a professional in the team tells the patient, what you did was wrong, you wasted your time. That is really frustrating for the patient and frustrating for the profession who proposed a treatment to the patient. And when something must be changed, I think that in the team, this is wrong, and we never have to tell it to our patients. So this was my biggest frustration.
Thank you. So if I will move on to one of the questions, which I think might follow on from that. We have a question from Renee Lemieux, so I apologize if I pronounce your name wrong. But the question is, what can we offer in terms of conservative treatment to an older adult with very severe scoliosis? So that I have a patient right now at the moment who's quite old with a very severe scoliosis, where I've referred them to a spine surgeon who has said that it's too late for operative management, and it's a very difficult case to deal with. So Fabio, and I saw from your Venn diagrams, which sometimes we cross over too quickly without establishing. But from your perspective, what do you offer the elderly patient with very severe scoliosis that may or may not still be a candidate for spine surgery?
Yeah, very interesting this topic, because elderly are a real challenge, because in many cases they're not suitable for surgery for the risk of connected to their comorbidities and a poor health condition, general health condition. So in these cases, my approach is a bit different. I rely more on bracing, also during the day, so a different approach with respect to young adults. I push for exercises also, but it's not always easy to have these people do exercises. But I think what we can do today, according to our knowledge, is to work with these two tools. Again, the bracing, but also during the day, and that supports a lot, and exercises as much as they can, and they accept this.
Okay, thank you very much. We have a question from Lisa Flexer for Sabrina, for Dr. Donzelli. So she writes that curve progression increases after age 50. Do we have any research or information about how general activity levels may affect curve progression? In other words, many people decline in general activity exercise in midlife and older years. Do those who maintain activity and meet general population fitness guidelines receive a protective effect from their activity levels? I think you've done some work in adolescence and activity. Can you talk about whether this holds true for adults?
I'm not aware about any specific research related to adult scoliosis. I can tell that scoliosis is for women in about 80% of cases, and therefore after age 50, menopause is given a big boost on degeneration. So that is a particular period of life in which degeneration can become very fast. And if associated to other factors like reduction in the physical activity, or also activity characterized by continuous overloading, weightlifting, for example, women caring to their husband with important disabilities, for example, can boost this degeneration. And in some cases, we see very significant progression in very short time. And so it's difficult. And as I was saying in my presentation, we know the average progression in time, but really what we see in everyday life, that there are some factors pushing a lot to curves, while other cases remain quite stable for a very long period, even with the curves 60 degrees or 70 degrees. And those patients are just complaining because of the deformity, the aesthetic profile, but we have patients without radicular pain or significant pain, just difficulties in supporting. They need to sit down after 1 hour standing, for example. then that is manageable. And so they prefer exercises rather than surgery. But so symptoms can be very different. It's very difficult. And probably a good study about sports activity in adulthood is a good suggestion, I think, is a gap.
Thank you very much. So now for Alessandra, we had a question for adults. Do you have a recommendation how many times PSSE should be performed per week? Do you have a protocol, a formal protocol?
Yes, I can tell you what we ask to our patients. Usually every day, about 20 minutes, 6 to 7 days a week. That's what we ask for. But sometimes patients prefer to do more exercises and have some free days. I think that at the start of the treatment for the first months, it's very important to have an everyday work, and sometimes also an exercise, a single exercise many times during the day to get sooner to the objective that we want to get.
Okay, and Eric,
Can I ask
are you
a
seeing the same?
follow-up?
Yeah.
Alessandra, can you talk about when you see the patients to train them as a therapist? So that was what you asked at home. What about when you recommend having sessions with participants?
Yes, that's how much I ask them to work at home. And I see my patient, I see him for about 1 hour every 2-3 weeks for at least 2-3 months. And then I reduce the frequency as soon as the patient is able to feels better and is able to work by himself. So I get to 2-3, and also usually I try to get to one session every 6 months, because they must understand that when the problem is an important problem, a severe problem, then it's for the life, not just for some months. Otherwise, they improve, they feel better, the quality of life improves, but as soon as they leave the therapy, usually everything starts again worsening.
Thank you, Eric and Alessandra. Alessandra, we've had a question with a number of upvotes. They're asking if in a patient with a lateral listhesis, and if I even may add in a rotational listhesis, do you modify the application of your PSSE for these patients, and how do you do so?
Yes, we discussed this topic in a team meeting some days ago, and usually we decide to look for correction, always in elongation, but just a small amount of movement, not to get too much mobility at the level of the lateral listhesis. And then when we cannot look inside the patient with X-rays, exams very often, then we have to listen to what the patient tells us. And if during the correction the patient feels better, or he has no problems, probably this is helping. But if during the exercises and in the first weeks of therapy something is worsening, besides X-rays or anything else, that tell us that probably we are on the wrong way.
Thank you. If I might go back to Charles with the surgical question, I hope you don't mind not being too controversial. So the question from Gabriella Barnstone: what is your opinion on vertebral body tethering, or I presume in this population of adults, it's ASC, and spine correction? Do you have any thoughts?
Yeah, absolutely. So vertebral body tethering, it's been around for a little while now. I actually wrote, I think the first case report that was in JBJS back in 2009. So I've been thinking about it for a long time. In the interest of time, I'll keep it relatively short. I think that true tethering is a growth modulation strategy. So you have to be growing. So that means you're a child. So it's really a treatment for pediatric spinal deformities. You know, anything else in an adult would be really a different concept. And I don't really know that there's good evidence that it's a good treatment strategy for adults right now.
Okay, thank you. Now, we've had a question. Do you use PSSE exercises or PSA treatment in your center in Leatherman Institute? Because I suspect, or I've heard that you might have some PSSE trained physical therapists. And how does that work? And how do you decide who to refer for that kind of management?
Right. Yes. So we have, I believe it was about 7, 8 years ago that we saw, the progress that your organization is making, and just the evidence is getting better, right, for specific types of physical therapy. So we had always had physical therapists at our facility, but we had them obtain specific training, and so we use them for pediatric patients, but also for adult patients as well. It's my general impression is that the patients that participate in the program are very, very satisfied with the treatment. I think my comment earlier was the biggest challenge is that we still have patients that live, 2, 3+ hours away. And so trying to get patients to travel to our center for treatment on a regular basis is very difficult. With the pandemic, telemedicine or video conferencing visits have become, much more popular and acceptable and reimbursable, from an insurance perspective in the United States. So that's something that our therapists are using more and more right now as well. But it's a continuously evolving program. So
with your recent trial, which you conducted, non-operative versus operative, I would hopefully diplomatically argue that probably your trial wasn't optimized to evaluate the efficacy of non-operative care on a PSSE level. So are you kind of going to look at that in the future, and how do you value the application of this kind of approach within these patient cohorts?
Right. It's just so complicated, because even if you look at the non-operative side not being standardized, you could also make the same argument for the surgical side, that there were a variety of surgical treatments used, and some of those surgical treatment strategies may be better than others. So you could argue it on both sides. But absolutely, I think that, surgeons are not experts at the physical therapy part of it. And we're not experts at the injection, pain management, which is also a very, very heavily used treatment bucket in this patient population, at least in the United States. And so I think that, we talked about a multidisciplinary collaboration. I think that we have to continue to communicate well, with our physical therapist, our orthotist, our pain management doctors who do the majority of the injections in the United States, and the surgeons, because there's a tremendous variety of pathologies, but there's also a tremendous variety of treatments. But absolutely, that study was not designed to look at scoliosis specific exercises specifically, or bracing, or injections, right? Just the whole bucket was non-operative versus operative. That was the dichotomy.
Thank you. So Eric, please go ahead.
Yeah, do you mind if I follow up? Dr. Crawford, I think you're part of one of the study groups. Can you comment on how non-operative care is documented in there? And would there be a chance for us to dig deeper in the data collected by the study group on the non-operative side? Or what's the limitation or the quality of that data?
Yeah, that's I think that's worth exploring for sure. I don't know if I have the right answer, because there's a couple different things that we're doing right now. I think that probably the surgery study group that has the largest number of patients right now is ISSG, and it could be interesting to see if there's some opportunity to collaborate. For sure, I think people could be interested in that.
Thank you very much. Is there, or do any of the panelists wish to say anything to end off, or are we happy? That's good. So I'd like to close off today's webinar with a message of thanks, hope, and goodwill. I'd like to thank Sonia, Prashia, and Kelly for the hard work in preparing the webinar, and to the presenters for giving up their precious time to allow us to learn. I'd like to thank all of you around the world for joining us. The world is a scary place right now with much suffering. Our society members, our patients, our families, we are all impacted by these world events. So I thank you despite what's happening around the world, for taking the time to continue to develop your learning to help others. And I hope personally and pray for peace and tranquility for all. If you're available, we'd love to meet you in San Sebastian in a few months' time, and I wish only the best for everybody. Thank you very much.
Thank you.
Thank you.
Thank you. See you in San Sebastian.
Mhm.
Thank you. Bye. Take care.